Good afternoon, everyone, and welcome to this very important webinar. Before beginning, I want to start with a land acknowledgement. Ottawa is built on unceded and unsurrendered Algonquin and Anishinaabe territory. The peoples of the Algonquin and Anishinaabe Nation have lived on this territory for millennia. Their culture and presence have nurtured and continue to nurture this land. We would like to honor the peoples and land of the Algonquin and Anishinaabe Nation. We would also like to honor all First Nations, Inuit, and Métis peoples, their elders, their ancestors, and their valuable past and present contributions to this land. My name is Yasser Naqvi. I am the former member of Provincial Parliament for Ottawa Centre and had the great distinction of representing an area which is covered by Somerset West Community Health Centre. I was also the Attorney General of Ontario and led the Institute for Canadian Citizenship, which is a national pan-Canadian charitable organization promoting inclusion, diversity, and active citizenship across Canada. On behalf of the co-sponsors of this event, the Ottawa Black Mental Health Coalition, Minwashan Lodge, Ottawa Community Partnership for Health Equity, Crime Prevention Ottawa, and the Social Planning Council of Ottawa, I welcome you to our second segment of our webinar series, Responding to Mental Health Crises, Learning from Models in Ottawa and Beyond. Now, a few housekeeping notes for you. To access French interpretation, please click on the globe icon on your Zoom toolbar. Usually it's located at the bottom of your window. In terms of audience participation and to ensure that confidential questions can be asked, we are using the Zoom Q&A function for this event. You will find a Q&A icon at the bottom of your Zoom screen. Click on the icon, to access the Q&A window where you can type in your questions. The Q&A portion will take place during the second part of this event, and I will be reading those questions and will be presenting or posing them to our presenters, and we will engage in a conversation, and hopefully we will cover as many questions as possible. If you like to access an auto-generated transcript, please click on the live transcript icon on the bottom of your screen and select Enable Auto Transcription. In this session, we continue our learning journey on the topic of mental health crisis responses. It's important to note that the Black and Indigenous communities have historically been underserved and inappropriately served by mental health services. Not having good options for mental health crisis response is sadly a matter of life and death. It is our hope that by showcasing some of the existing response options, both here and abroad, we as a society can have a better idea of how we can do better to serve some of our most marginalized family, friends, and neighbors. We must work together to end racism. There is a quote from the Crisis Prevention Institute that says, "Behavior impacts behavior. The empathy you show to a person in crisis can transform the situation." Peers have an incredible advantage of accessing that power of empathy more quickly, more deeply, and more genuinely than others who have no shared experience. Without going any further on behalf of the organizers, I would like to acknowledge the tragic death of Carl Reinboth. Carl was a beloved and respected harm reduction worker at the Somerset West Community Health Centre. Carl's lived experience made him a peer to the drug-using community and gave him a greater understanding and empathy for those that used drugs. The song we just opened our webinar with, Emma Stevens' rendition of Blackbird, was a favorite of Carl's. Just as we took a moment to honor his life and legacy in song, I now ask that we do the same with a moment of silence. Thank you. In today's webinar, we have the honor of hearing from members of a peer support outreach team that is based out of the same community health center that Carl worked at. I'm excited to hear from DOPE members how they leverage their shared experience and combine it with other good practices to help their peers during time of crisis, as well as regular interactions that help prevent crisis. DOPE, which stands for Drug Overdose Prevention and Education Response Team, offers assertive evening outreach to vulnerable and isolated community members in 3 Ottawa Community Health Center catchments. Services focus on increasing access to health promotion, prevention, treatment, and harm reduction programs and services among high-risk people who use drugs. Without further ado, we're really excited to have 3 members of the DOPE team with us. I'm going to pass the proverbial microphone to Hannah Haynes, who will introduce herself and the other members of the team and make a presentation. Hannah, to you.
Thank you, Yasser. We are excited to share with all of you about our program today. It's timely as we're presenting during Mental Health Week. As Yasser said, my name is Hannah Haynes. I'm the program coordinator for the DOPE response team. And
my name is Jason Hayes, and I'm a community worker with DOPE Response.
And my name is Angeli Miles, and I'm also a community worker with DOPE Response.
We are presenting in our personal protective equipment today, showing you our commitment to COVID safety during these times. So we're representing the DOPE response team today. As Yasser said, it stands for the Drug Overdose Prevention and Education Response Team. We are working in 3 catchments in Ottawa: Somerset West Community Health Center, Carlington Community Health Center, and Centertown Community Health Center. This is a program that's made possible through a financial contribution from Health Canada. We started in September 2019, and we're running for 3 years as a term program.
So as program review, DOPE Response Team is a community health center peer delivered program. It's offering assertive outreach in Centertown, Carlington, and Somerset West catchments during non-traditional hours. The project focuses on increasing access to health promotion, prevention, treatment, and harm reduction services among high-risk isolated people who use drugs.
Sorry, catchment areas.
You're reading down here.
Right
there.
Thank you. So usually there is 1 team per catchment area during a shift. These are massive catchment areas that include many parks, OCH buildings, alleys, and other hotspots which we've identified. Some staff report to walking over 20,000 steps in 1 shift. Many benefits to doing outreach on foot. We are very visible in wearing our team uniforms and large knapsacks, and are now recognizable in the community. A lot of our engagement is done with just running into people we have met before or introducing ourselves.
So here you can see our catchment areas on the map and just how huge they are. And rain or shine or snow, we're working in those catchments, connecting with people. Oh, that's me. So what is harm reduction, right? Like some people, they have their own idea. Some people have no idea. So it's an evidence-based, client-centered approach. It acknowledges that people have the right to make decisions about their own health and lifestyle. People who use drugs can often be stigmatized from healthcare supports, and as a result may mistrust the healthcare and social services and become even more isolated. People who use drugs deserve an approach that's respectful, caring, non-judgmental, and compassionate. They must be met where they're at, otherwise their needs will not be met.
So harm reduction programs continue to get more recognition and are ever expanding. Harm reduction roots are from drug using community. Without the knowledge sharing and activism of these communities, there would be no harm reduction programs in our community health centers. Harm reduction aims to simply reduce harm. Example, new drug using equipment, reduce isolation, keeping used syringes out of the community, and reducing problematic substance use, etc. We support people who use drugs, and it is not our goal to convince people to stop using drugs or to shame them in their lifestyle and decisions. Harm reduction supports self-determination.
So just a little snapshot of the opioid crisis in Canada. So the rate of overdose deaths increased from 8.4 to 12 per 100,000. And these are some old numbers from 2016 to 2018. And we know anecdotally that things are much worse. 94% of overdoses happen by accident. And then to give a little bit of a COVID context, and how things are exacerbated, the pandemic has led to fractured supply chains and street drugs to become more potent and unstable. It's caused more people to use in isolation. And this is from last March, so not super recent, but to give an idea too, 300 overdose deaths in Ontario happened in March 2020, with only 56 deaths due to COVID. So this is still very relevant of an issue.
We've lost thousands of loved ones to the opioid crisis, which is ever worsening due to the war on drugs, toxic drug supply, and the prevalence of fentanyl and carfentanil. The crisis is only getting worse, and COVID-19 has worsened an already devastating epidemic. The crisis is underreported in the media and overlooked by policymakers, and it is important to question and to be critical as to why this is given the fact that so many people are dying.
And to give an Ottawa perspective.
So this is a graph that shows how overdose deaths are continuing to increase in Ottawa. While the year ends in 2017, we have no doubt the rate of deaths have continued to increase.
So what about our program approach? What makes us different? So the Dopa response team is staffed by community workers who are people who are from the drug using community themselves. They have either lived or living experience using illicit drugs. This peer-based program employs the knowledge, expertise, and social networks of people who use or have used drugs. Staff are hired not despite, but because of their past or current lived experience. We're working in non-traditional hours from 5 to 11 p.m., 7 days a week in the community. We recognize that there's a service gap in community services where services are often closed at 5, and yet the need for harm reduction and mental health supports persist.
Community workers are often able to create connections and build trusting relationships with community members that otherwise would not engage in healthcare services. People who use drugs need harm reduction gear and opportunities for connection after 5 p.m. too.
So the next two slides list our program goals. Identifying and preventing opioid overdoses is one of the core pieces of our program, but most of the time we spend actively participating in creating safety for our target population is in so many ways. Whether it's advocating and bearing witness for someone that the police were called to intervene for, or whether it's a partner agency who requests an intervention with someone whose behavior requires further support, someone who is struggling, we run into in the community and creating a safety plan for that person, or mediating and de-escalating conflicts between people in the community. There are endless mental health crises, psychosis, suicidality, paranoia, loneliness. We see this daily and connect and engage to assist as we can.
So despite our target population who we're wanting to work with, who are isolated, high-risk drug users, we are often seeing all of these other crises that are happening. There we go, sorry. So some of our program goals more globally: to reduce isolation and promote belonging by community, connecting with community. We provide and build on peer support and knowledge sharing. Oftentimes we're hearing from the community themselves when they're seeing trends of what's happening, whether it's with the police, whether it's with the drugs that are in the community, all of these different things. They often hear things first, and we can help share that information. We are reducing HIV, Hep C transmission by providing harm reduction equipment such as syringes, pipes, and other sterile gear to people who are using drugs. And then, as Jay was just mentioning, we're responding to and preventing drug overdoses as well as other crises in the community. And we're often liaising with emergency services, whether we're the ones who have made the call to them or we're connecting on the ground with them as we are seeing them. Oh, it's not going to the next slide, guys. There we go. Sorry.
Another thing we do is we provide harm reduction education to community, including providing naloxone medication to block opioid overdose and training on how to administer. Collaborate with peer volunteers to engage isolated and high-risk program recipients that do not otherwise access services. Refer and accompany program recipients to appointments and connect them to other services, housing, medical, practical supports, etc. And safely dispose of used syringes and other harm reduction equipment found in the community.
So we ask a lot of our community workers. They are doing really hard work with really hard situations in the community. We provide a ton of training. We have regular community of practice sessions with our community workers. And often this is an opportunity to share relevant learnings, participate in workshops, and then also offering space for wellness and support for each other. We also encourage regular ongoing training opportunities like active listening, applied suicide intervention skills training, CPR, nonviolent crisis intervention, trauma-informed care, understanding boundaries, confidentiality, the list goes on. That's just to name a few. Our community workers also bring with them already a spectrum of personal and professional backgrounds and experiences. We're also lucky to have an employee assistance program available to all of our staff. We have an on-site clinical supervisor available. And the team also, and probably this is the most important, they really support each other in the work that they're doing and offer each other check-ins regularly. These are some of our program benefits that we've noticed doing outreach.
Regular community cleanups of discarded syringes, direct knowledge transfer of current drug trends, building connections for pathways to care, i.e. referrals to case management services, accompaniment to hospital shelters, medical appointments. Again, the list goes on.
And do connection with community members who are often isolated and have few supports.
Sorry, my bad, Angelique. Back to you.
All right. Increased naloxone access and overdose identification and prevention training in community. Increased access to harm reduction supplies during non-traditional hours, and crisis intervention and decrease in calls to emergency services.
So we're often on the ground and able to de-escalate and prevent things from escalating much further and leading to harms to different community members.
So some of this program statistics. Accompaniment to appointments, we provide food, we do harm reduction teaching, drug warning, education, and safer injection practices, and many, many referrals.
So these stats are up to March 31st, so they're not as of today, but, and.
So since the program launched in September 2019, we have made 19,666 connections and counting. Again, up until March 31st of 2021.
So since September 2019, we have safely disposed of 113,331 needles, big number.
A whole lot of needles.
That's a lot, probably more since that. Gave naloxone training to 281 people, distributed 2,657 naloxone kits in the community, administered naloxone to 37 people experiencing opioid overdose. And the numbers are definitely a little underreported. So there's definitely more than those since then.
Yeah.
Sorry. There we go.
Yeah. So we often receive positive feedback about our program while on shift. And that makes our jobs feel very meaningful. And these are just a few examples of some of the things that we hear. So I think the program is wonderful. You bring stuff to those who need it because sometimes we're too sick. So thank you. Eventually, I want to do what you guys do, the Dopa spread team we're doing, and through our program recipient. It has really opened my eyes to how strong the fentanyl is and how quickly an overdose can happen anytime, anywhere, with any amount. And that's from a Red volunteer. I'm so glad to have another resource rather than just calling police because I don't know what else to do. And that's from the Tim Hortons store manager.
I think another quote we've received was, I think what you're doing is amazing. You meet those.
Oh my gosh, sorry guys.
No, it's okay.
Delayed PowerPoint, there we go.
There we go. You meet those who can't make it to the site, and you meet people where they're at, in a place that they feel safe. It's awesome that you're out here because some people I know don't feel comfortable going to the sites because they don't want people to know that they're using drugs or who they are. Stigma is still real, and at least you're out here connecting with people who are still alone. And this is from another program recipient.
So I have some quotes as well from some of our Dope Response team members that felt relevant to share. So when working with clients, I remember my trauma-informed training. I use my naloxone training in overdose situations. I use the grounding skills I've learned in high stress situations, as well as the de-escalation skills I've learned. Another quote is, if I can get the PowerPoint to work. Sorry, guys. Oh, why? Technical difficulties is not our strong suit. Working in high stress situations in the community is. I don't know if Ahmad is going to do it for us. Oh, I don't know if I should touch it. I'm going to just keep reading them and hopefully they're doing it on the back end. I recently worked my best shift since starting with the Dope Response team. A client we see there we go. A client we see regularly in the community who doesn't use opiates had fentanyl contaminated crack by accident. Last time we saw him, he let us know we saved his life since he never would have thought he needed naloxone kits if it wasn't for us. We always encouraged him to have naloxone with him just in case and trained his roommates on how to use it. And my favorite quote is, I've been gaining self-worth. So, Jay.
Not just
next one.
Oh, sorry.
No, I lied. One of us was supposed
So not just clients and business owners benefit from this program. This program has been very personally meaningful to many staff in many different ways. We are lucky to be on such an open, hardworking, and badass team. No lies there.
Keep it going.
Yeah. We are always looking for opportunities to connect and collaborate with partners so we can support isolated individuals. How we can work together, collaborate with partners and community members to identify high-risk areas, provide on-site workshops, training, education to community members and staff. Open to other ideas to work together.
We're always looking for other ways to connect with isolated folks who are not connected, and so it's a constant work in progress. We just wanted, oh, I went too far because I'm click happy. There we go. So to give an idea of what our work actually looks like, just quickly, we wanted to share a few example scenarios that we encounter super regularly. Sometimes all of this and more can happen in just one shift alone. These are some common examples and demonstrates the cascade impact of the work that's happening in the community.
So scenario one, building rapport with a client on the street results in long-standing relationships, connections with each other supports, and client refers us to other clients.
Receiving a call from a concerned neighbor about someone using drugs in a park, we can attend to support instead of the Ottawa Police Services.
Scenario three, responding to an overdose in the community, resulting in harm reduction teaching with the Ottawa Police Services.
And four, connecting with the roommate of someone who uses drugs, providing naloxone training and overdose identification. Person responds to their partner's overdose, in turn saving their life.
So all of these examples are showing, some of them are not necessarily with our target population, but because we're out there in the community, we are still reaching that target population in different ways, and also connecting with all these other community members who aren't high risk isolated drug users, but who have an impact on those folks when they run into them. So offering that education opportunities and a human face to who they're working with is really, really helpful. So how can you reach us? Because we love to hear from people. Please get in touch with us. If you would like cards at your program, you can always just give us a call, reach out. We have program posters as well. And there's a link in the chat with a link to these posters, but we can also bring you paper copies. We did it. So we're gonna open it up to questions. Yes, sir.
Fantastic. Well, thank you to the entire Dope team. Thank you very much for your energy and enthusiasm, number one. This is a really important work. And as you mentioned yourself, you're saving lives, and there's no value that could be attached to that. So thank you very much for sharing such knowledge and insight. Just a reminder to everyone who's attending this webinar that we are going to be now doing Q&A session. So we encourage you to type your question in the by clicking the Q&A icon, and Hannah and I will go through those questions, and we will do our very best to answer as many questions as possible. I was already having a little peek and noticed there's some really good questions that are coming in. But Hannah, maybe I can start with a question or two as well. As I mentioned, I had the great honor of serving the community as a member of provincial parliament. I remember way back in late 2007 and early 2008, one of the most earliest issues I worked with, along with Somerset West Community Health Center, was to get funding from the provincial government for harm reduction programs, and making sure that when it comes to clean paraphernalia for drug use is available, that there be a mobile team that operated out of the Somerset West Community Health Center that went into the community helping members of the drug using community to have clean syringes and other supplies, etc. Can you explain to us how this program, the DOPE program, is different than what was being served by Somerset West Community Health Center in the community, and how this is an evolution of providing better harm reduction services in the community?
So I wouldn't say better, yes, sir. I would say that we complement the other programs. So Somerset West Community Health Center, as well as other CHCs and agencies, have just a ton of other harm reduction programs that we offer. We have a community treatment site here where people can come and use their drugs without fear of criminalization, and have the supervision of nurse and other care workers, including community workers. We have community workers embedded in all of our harm reduction services. And I would say that we complement each other, and we can check in with each other and really align how we connect with folks. That's at Somerset West. And then with our partner agencies at Centertown and Carlington, we're again just building on the existing harm reduction services and really it's an educational opportunity for our center, their centers, and we're all just growing and learning together. We're really assertive in the community every day in people's faces, trying to connect with folks and trying to support folks. And we're just one other branch of how to connect to all these other great services that are offered.
Okay, great. Thank you. We also have a very important question from the Ottawa Black Mental Health Coalition and Minwashin Lodge. And that is, in what ways is this program effective in helping members of the Indigenous and Black communities?
It's a great question as well. So we, our target population is isolated high-risk drug users. So those might be people from racialized communities, from the Black and Indigenous and other communities. We, at Somerset West, we are committed to, sorry.
Oh my God.
It's an alarm and not a phone, which is great. So we We have a health equity committee here at Somerset West, who the focus is issues of inclusion. We have an anti-racism and anti-oppression policy, which the Health Equity Committee actions throughout all facets of the center. We, for our team in particular, and I know it's the same for the center as a whole, we're committed and prioritize hiring staff from diverse backgrounds, because just as this program represents people who have those experiences, who have been criminalized themselves, who have faced oppression and racism themselves, are the best to engage with those folks as well, because those are the folks that are oftentimes more vulnerable, oftentimes more isolated in their communities.
So can you give some examples of how you're incorporating culturally informed responses to better serve Black and Indigenous people through this program?
We do have Indigenous knowledge keepers at our center who provide ceremony to both staff and clients alike. We do try to incorporate as much as possible those opportunities to bring that knowledge together. We do have medicines as well at our center that are for staff as well as clients. And we do work closely in our harm reduction department. We do also have ACB, HIV prevention workers, different programs. And again, as I spoke earlier, we try to support each other, align to come together and meet those shared target population folks.
Okay, great. Thank you. And this is very important. And I mean, we have to obviously pay particular attention to these very important aspects. So thank you for sharing that with us. You mentioned this program is a 3-year pilot. It is funded by Health Canada.
Correct.
We do have a question as to if you can share with us what is the annual budget for this program, and are you already planning how to make this funding sustainable in terms of the outcomes that you're already seeing in the community as a result of this program?
So I don't have the numbers for our annual budget off the top of my head, unfortunately, to share. We do, so again, it's that cascade of impact. So we're enhancing having community workers and staff with lived and living experience through this program, but then more and more of our harm reduction programs are taking that on as well. Our partner CHCs have hired on staff, more staff with lived experience, because they're seeing the benefits of having people with that lived experience to connect and engage and have those meaningful outcomes.
Okay.
Work in progress, continued work in progress.
Absolutely. And I mean, these things always takes time. What has been your biggest barriers in getting this program up and running?
You guys want to, I just want to make sure I give opportunity.
Absolutely.
Do you guys want to talk about personally what has been challenging in terms of barriers for yourselves in joining the team? But you can also opt out. On the fly, sorry guys.
Yeah.
You're good too. I would say, so getting the funding in the first place was a lot of work, and then getting it, and then really structuring things for wellness as well for staff has been a priority and a work in progress as well. As we're a community health center, I know this is already a commitment to our staff, and then having staff with such a diversity of their lived experience themselves, having how do we continue to build accommodations for those staff, build on existing supports, making sure those supports are well aligned for staff wellness and ongoing success has really been a priority. I forget the question. What's the question? Yes. Oh yeah, challenge to get up and running. Yeah. And then as well, thanks Jay, as well, COVID has been great. COVID's been super, super great. So accessing social housing, accessing rooming houses is already challenging because of the paranoia in the community, the isolation. And then with COVID on top of that, where, you know, sometimes we have the police who ask us what we're doing out in the community. Sometimes we have landlords that don't want us to come by because of COVID, but we're doing everything safely in our personal protective equipment and checking on folks when they're much more isolated and vulnerable. So just having those ongoing conversations, making sure that we're demonstrating that we're there for health and safety, we're there for wellness, and that it's a overarching, it has positive overarching consequences.
Well, I mean, this is it. I mean, you mentioned that you started in September of 2019 and the pandemic started shortly thereafter. So there's a whole different element to this program, I'm sure, that you had not even envisioned or planned for, that you had to incorporate as part of the service provision in the community.
Yes.
Right? Lots of good questions are coming in. So I'm just quickly scrolling. So Hannah, here's a question. When performing resource referrals, are these with predetermined partnerships and organizations under an agreement? How does that whole process work when you are referring people to different resources in the community?
So certainly it's much easier when we're referring people to our CHC and our partner CHCs at Centertown and Carlington, because we're much more up to date and aware. You know, speaking of challenges earlier, like COVID, like what is up and running, what's not, how do people access it, has really also been an ongoing high learning curve of, because we don't want to send someone somewhere and then it's actually closed, or they're going to have a hard time because they can't wear a mask at that appointment, or that kind of thing. So it's much easier for us to do it at our own CHCs, but then we're in the community with those other social service agencies, and some of our staff are accessing them themselves in their personal lives, and they also have a better idea about what's running, how it's running, and they can speak to those things. And we offer support as well and accompaniments, as we mentioned in the presentation, so that if people have a lot more anxiety about going to a healthcare appointment or a housing appointment, things like that, we're able to be there and advocate and support them as well.
And so I think this question is coming from a community partner. How would a staff member from a community partner could refer a client to the DOPE program?
Yeah, so sometimes it comes in from all kinds of different ways. Sometimes we have a healthcare provider, sometimes it's a social service agency, sometimes, and this is often what's the best, is when a person themselves, they can self-refer. There's no referral process. We have our phone number, people give us a call, we get back to them right away. And if it's during our service hours, we try to see them that same night as quickly as possible. We are very much aware that it's, you know, in the moment is when we're going to get something done with somebody, when they're motivated, when they're feeling able to. So we really recognize and respect that and do our best to work with that. Oftentimes I find, you know, if I have a housing provider as an example, who's referring somebody to us, if that person doesn't want to see us, then we can't force that, and there's nothing we can do, but we can follow up and just check in and just, you know, you don't want us to come by today, that's okay. But we can still keep coming by and just making sure they answer the door at least, or answer their phone or whatever it is.
Yeah. Can you speak to your relationship with Ottawa Police Service in the delivery of this program, and how does that relationship operates? Are there challenges? Are there opportunities here? Is there a lot of education that's taking place with Ottawa Police Service as it relates to members of the community who use drug and their health circumstances?
Yeah, 100%. It's a really good question, especially because our program hours are when there's not a lot of other agencies working. We have, at the program outset, we did quite a few presentations to the platoons of the, well, what are they called? The frontline officers who are in the community, to let them know who we are, one thing, so that, you know, don't stop us every time you see us. So hopefully they get to know us a little bit, but then also to talk about like what we're doing, why we're doing it, how we can work together, because we do want to work together. Not every scenario where the police are called or are present requires police presence. So we do try to navigate that with the police. As well. We talk about how the drug trends can really impact people's behaviors. Sometimes people are just really unaware of what's happening and what they're doing. We've certainly had, by nature, all of our target population is criminalized. You know, somebody who's using illicit drugs is by definition a criminal. So we still believe that they deserve healthcare and supports. So how can we connect with the police and have these conversations and keep going? We're very active with our community police officer in our catchment, and she's very supportive. And we also, we're about to have some education sessions with the new recruits. It got slowed down with COVID, but we're hoping to continue just to, again, as we mentioned before, humanize what's happening and who people are interacting with. I have had staff stopped just because of how they look working in the community. And we've certainly had negative commentary at times. And we're able to really remain professional. And whether it's malintended or not, we're always open to having those conversations to, challenge some of those narratives as well on our end. If there's something that we say that Ottawa Police Services wants to question, we're there to have those conversations. We're committed to that because we see the more positive outcomes for the community members as a result.
So what I'm hearing from you, there may not be 100% acceptance of a program like this, but there is understanding and there is an ongoing conversation or dialogue and education that's taking place as it relates to Ottawa Police Service and the job that they have to do, but the very important work from a healthcare perspective that you're doing within the community.
You got it.
Okay, that's very good. Now, your program is important. It is making an impact. You also showed us a slide about the catchment area that you cover, which is basically the 3 community health centers in the downtown core, Somerset West, Centertown, and Carlington. I'm seeing a lot of questions in our Q&A chat, people asking, how about Overbrook? How about Lower Town? Are there any plans to look into expanding this program to other places in the community where there's a lot of members of drug using community? I mean, people are everywhere who are using drugs, but are there programs? Are you having conversations with other community health centers in Ottawa to see if this program or similar could be expanded or similar programs could be started?
We're certainly using our experiences as opportunities for other agencies, whether they're CHCs or others, to be able to hopefully replicate or build on what they're already doing. I know there are some agencies already doing similar type work, which is amazing, and we've learned from them as well, and we continue to collaborate because there's so much shared learning to offer each other. But that is one of our goals is, hopefully we can be like, look how great we are, because we are great and all the hard work we're doing, and look at all these numbers, because I make these guys do stats so hard to show, validate the work that you're doing, because this is how we can show what you're doing to funders, to other agencies, and really just demonstrate the need and the importance.
Yeah, absolutely. I mean, and data is so important, right? I mean, we always talk about sorry, we always talk about to take evidence-based approach, right? That drug use, addiction, and mental health, these are healthcare challenges. These are not criminal issues, and I think data associated with that to make that point is important, and how these programs is part of healthcare delivery. Is an important point, and that evidence, that data is going to really make an impact. So yes, to the team, data is important, and more that we can share with other orders of government, I think more helpful will be in the long run. You did also talk about stigma and how some people may not come to the community health center to a safe injection site because of the stigma. And they don't want to be seen or others to know. Are you doing work in terms of targeting stigma and how you are sort of working with the users and the community writ large, if any in that regards, in terms of reducing the stigma around drug use?
You guys want to jump in?
Well, I think we're also speaking to a lot of business owners around just to kind of get rid of a lot of the stigma. A lot of people were unclear about what our role was at first in terms of talking to people on the street. But I think we've done a little bit to change some people's stigma or what they already have of existing of drug users out there, in speaking with some of these business owners on that side of it. Jonathan, Jay, did you have anything? From the business owners.
Again, yeah, it's a lot of that is in speaking with community members, oftentimes who aren't a part of the drug using that part of the community, and explaining what we're doing and where we come from. And so a lot of times when we're speaking with folks, it comes as a surprise to a lot of them that we're out there doing this and that we do have that lived experience. And that's why we're here and why we're so passionate about it. And the reaction most times is really positive. People want to know more. They want naloxone training. They want to know that they can call us to check on folks when maybe it's not an emergency situation. So I think just the understanding that like everybody needs care.
Yeah.
And that's really a message that's coming across loud and clear.
Yeah, you know, oftentimes, Yasser, even within our own CHC, we're having to advocate and say, you know, that appointment's not going to be accessible for this person, and here's why. And oftentimes it's not malintentioned, it's just that people don't understand or didn't think of it. It's like, okay, this appointment's at 8 a.m. This person's going to show up with their health card and their ID, and they're going to sit quietly while they wait for their appointment. And like, that's just may not happen for somebody. And so sometimes like breaking down that stigma can also be just those little conversations that you're having with your colleagues, or, you know, when one of these guys uses their skills in a crisis situation, that the police and emergency medical services is there and they're witnessing their expertise and their professionalism. And that really changes people's minds. It's like, oh, like this is an active drug user, but look at what else they're capable of doing. You know, they have so much to offer, and it's really, we're here to support and guide and offer ongoing trainings and things like that, as I mentioned, but all of those things tend to break down that overall stigma.
We talked about COVID. COVID changed a lot. Streets are more empty, businesses are closed right now. But those people who are homeless are still homeless, but they have an additional risk now of this virus, a deadly virus. How has your approach changed in this period? How have you done, of course, beside protecting the workers who are providing the program and all the important precautions you're taking, and it's so good to see you that you are in the clinic right now at the community health center, and so you are, you know, taking all the precaution yourself, even in that setting. On the streets, as the workers out there, what are they seeing differently, and how are you approaching through this program to help people as a result of the pandemic as well, on top of their addiction and mental health issues?
Well, my goodness, yes, we could talk about COVID all day. The challenge is the tension between the priority of COVID in people's lives, let alone the reality of the risks that many of our clients are much higher risk. They have, you know, compromised immune systems, malnutrition, all these things. But it's really not the priority in their life, right? Like they just overdosed twice that day. They don't know where they're going to stay. As you mentioned, you know, they can't find the drugs that they just were robbed of. They were just beat up, whatever. Like the list goes on of the terrible things that people are surviving. And then we add on COVID. And as one of our slides showed, like there were 300 overdose deaths, and those were just the ones reported. 300 overdose deaths in Ontario, and only 56 were related to COVID. Now, I don't have the accurate stats right now, but I can understand why it's not the forefront of concern for a lot of the population we're working with. And so just like all of our other safer injection practices and drug warnings and all these other things, you know, we're having a conversation with somebody or an interaction, and we're gonna just slide in some information about COVID. We're just gonna offer them a mask, you know, we're gonna give them some hand sanitizer if they want it. And, you know, we're so lucky to be in a community health center who has all the information as up to date as possible about the current COVID situation, where to get their vaccine and when, and we can support them getting there. You know, they can get tested for COVID, all these things. We are so lucky that we have that information, and all we can do is offer it to people as appropriate. We're screening everybody as much as we can as well for symptoms when we're interacting with them, and then we can just support as best we can to engage in those healthcare options, just like we do with everything else we're talking to them about.
Yeah. We've got 10 minutes to go, and there's a lot of questions, so let's do a few rapid fire questions. See,
Oh my God.
so there's a lot. Yeah, let's like make it like a game show. There's a lot of course interest in the profile of the individuals that you're helping. So can you give us a sense of age group? Are you dealing with teenagers, people who are under 18? Are they mostly older individuals, men, women? Can people from LGBT community? Can you give us a bit of a sense on that?
Yeah, so for sure. Off the top of my head, because I pull all the statistics for our program.
Hey, there's data again.
What's that?
Here's that data again.
Here's the data. Yeah, like here's what's so important. So we certainly see trans identifying individuals. We certainly see a lot of women. We don't do the stats on any of our demographics from racialized communities, but it's something that we could speak to anecdotally. Basically, we see anybody who is willing to see us, as long as they are those folks who, you know, are high risk for overdose. So sometimes we're seeing other people just because they're in the community, but then we try to refer them to other services. The Snapshot for drug using communities in Ottawa is very much, you know, if you're an opiate user, you're using fentanyl right now. If you're a stimulant user, you're using meth or crack. And overarching is white males. That's who we see in our services. That does not mean, I know the stats are out there, I just don't know them off the top of my head. There are high percentages in all the other demographics who are more vulnerable, more at risk, women, trans folks, different racialized communities. So we're just doing our best to connect, get out there. Being a part of those communities sometimes ourselves is what really can help navigate. You know, we had one Somali staff who we were in the community and we ran into another Somali, and he was just he's like, well, now I'll talk to you, you know, whereas he would not have talked to us otherwise. So it makes such a huge difference having representation from those communities on our teams who really can just build that trust.
You spoke about a relationship with Ottawa Police. Do you have similar relationship with Ottawa Paramedic Service and the fire service?
I know the center as a whole, when we opened our community treatment service, then our site, then we had them come in, we had them take a look. We wanted them to feel comfortable and know who we were and who we were working with as a center. And then we are often calling emergency medical services and not the police, because it's usually a medical scenario where we would have the need to have further supports. Sometimes we're referring to shelters, things like that, who they're already knowing. We're aligning with the Shepherds of Good Hope and their targeted engagement diversion program. And sometimes the paramedics are the ones who are doing those transports, because otherwise the timing can take too long. So we have ongoing, just continuing to build and educate as we're working with them.
Question is, if I want to refer a person to your services, do I just call the number in the postcard that was shared to everyone on this webinar? And how quickly would a worker be able to respond?
So as I mentioned earlier, somebody during our shift hours, which is on the postcard from 5 p.m. to 11 p.m., somebody should be answering that phone all night during those hours. And we try our best to respond as long as the person is in our catchment and open to us working with them. If it's outside of those hours, people can leave a message and then we'll respond during our shift.
Somebody asked that they work with people from immigrant and refugee communities. Are you able to provide services in different languages? I'm assuming English and French is probably, of course, available, but any other languages?
Yeah, because we're Health Canada funded, we do our best to have at least a 50% French speaking rate in our team. And then it's whatever members whatever staff we have on our team at that time who could speak those languages. Now, Somerset West does have great interpretation, probably won't be available from 5 to 11, but it could be something if the person was interested that we could try to set up.
Okay. Here's a good question. This may not be in the rapid fire category. Where do you see gaps in services that you provide, and what is needed within the community? Are there specific tools or supports that are missing?
Bathrooms. Oh my goodness.
Bathrooms.
Especially during COVID, it's just so inaccessible for us to go to the bathroom, let alone people who don't have a place of their own that they can go to the bathroom. So that's a huge one. Do you guys have anything off the top of your head?
I agree with the access to washrooms at this moment.
It's
Yeah,
a huge
that's a
one.
huge one.
I think due to COVID, sorry.
If you can't afford to pay for a coffee or a chocolate bar, then you're not a paying customer and you're not welcome to the facilities. And that's often like the closest bathroom may be like a couple miles away.
Yeah, and to Jay's point, that goes back to the stigma too, because we so often see the folks we work with, even if they bought a coffee, are denied services in a restaurant or a coffee shop to use the washroom. So that's huge. I would say, Yasser, too, like during COVID, having access to other social services where people can take showers, just have a spot to be and not asked to move along, has been exacerbated with COVID. But then also during our working hours, there are so few other agencies who are out there connecting with people who aren't just moving someone from one place to another. That I think that's a real gap in our services in this city as well. Like having an evening drop-in available. Some have started recently, certainly in our catchment, which is amazing, but there's so many other places where there's nowhere to go at night.
Yeah. Let me just ask this one question very quickly, last one, around, so your focus is working off hours, sort of. Can you just quickly speak to services that are available in the community, maybe the catchment area that you serve during sort of work hours, and how does that relationship works between work, having full coverage at all hours in terms of services for members of the community who use drugs?
So for people who use drugs at Somerset West Community Health Centers, we only have a few minutes. So we have a safer supply program where people, if they wanted to, it's like a substitution therapy program for people who use drugs. We have medical care. We have our supervised injection site. We have a needle exchange safer inhalation program where we're handing out gear on site for people who need it. We're handing out food as well. Oh, help me, you guys. We have homeless crisis outreach who they work similar hours to us. They're also a pilot program, and we collaborate with them often in terms of identifying and referring people who are unhoused or unstably housed. We have quite an extensive list. That's like off the top of my head, Yasser. And that's just who are specifically people who use drugs. And like anybody would also be welcome to be using all of our other services that we have here, like rapid HIV testing, dietitian. I said the gear room. Okay. So there's lots of other services as well. And that's just our CHC. Carlington and Centertown also have extensive resources, and we're just always trying to connect and collaborate with them as well.
Well, listen, we're at the end of the hour. Thank you very much. First of all, just thank you for everything you're doing in the community. I hope you're getting an opportunity to look after yourselves as well, and all the members of the DOPE team. It's extremely important. You are saving lives. You are trying your very best to make lives better of others in the community. So thank you. And I loved your energy and enthusiasm. It just comes through, even we're communicating through a screen right now, but it's quite evident, the amazing work that you're doing. So thank you. And I want to thank everybody who has joined. There was a lot of good questions, and we tried our very best to answer as many questions as possible. And kudos to the Dope team for having the energy to share all the information. So Miigwech and Marcy for participating today. I understand that there is going to be an electronic survey that will show up in your web browser when this webinar ends. So please complete that survey. Will help us make this series better due to your feedback. And we look forward to seeing you in 2 weeks' time for the next webinar on the same topic. So thank you very much and have a good rest of the day. Bye-bye.
Thank you, everyone.